I'm Ed Bluth, and I'm going to be talking first about carotid ultrasound, followed by a talk by Dr. Shweta Bhatt on the thyroid, followed by a talk by William Wan on the salivary glands. So it's sort of we're introducing color flow Doppler, we're doing thyroid biopsies and thyroid nodules, and an assessment of the salivary glands. So I hope you enjoy the interests, but we're doing everything that's in the neck. So I'm going to be starting first talking about the carotid ultrasound. Excuse me one moment. And what we're going to be talking about in this session is the two different components of the ultrasound examination of the carotid vessels, which is first plaque characterization and then flow-limiting stenosis. Now, as many of you know, there are really two independent risk factors which cause stroke. One, of course, is flow-limiting stenosis, and the other, which is underappreciated, represents the determination of who's at risk for embolic stroke. So with pathologists, for a long time, they've well understood that you can assess and identify plaque which of two different components. One is just simple fibrous collagenous plaque, and the second form of plaque is fibrous collagenous plaque, which has areas of intraplaque hemorrhage. So one of the ideals of imaging is to determine the different forms of plaque, and can we successfully do this with imaging. And I'm here to tell you that actually with ultrasound we're very successful in characterizing plaque, and I've written extensively about this as well as others have done this as well. I've divided plaque into two different forms, the heterogeneous and homogeneous types, depending on the degree of sonolucency in the plaque itself. The Europeans and Australians have talked about the same type of issue, but they've divided it into four categories, type 1 to type 4. Type 1 and type 2 are, they call it echolucent, but primarily it's heterogeneous plaque, and 3 and 4 is homogeneous plaque. So again, and we have really a common vocabulary if you analyze and read the papers carefully. For heterogeneous plaque, the differentiation is more than 50% of the plaque volume is sonolucent. In type 1 plaque, it's completely echolucent, sonolucent. In type 2, it's more than 50% sonolucent. Type 3 plaque is less than 50% sonolucent, and type 4 plaque is completely uniformly echogenic. And that's the type of plaque that I'm calling homogeneous plaque. So let me show you some examples, and again, what we're talking about. So again, we're talking about the ability to identify plaque the way pathologists can when the plaque is removed. Fibrous collagenous plaque is one type, which we're calling homogeneous. The other is fibrous collagenous plaque, which contains areas of intraplaque hemorrhage, and we're calling that heterogeneous. Now, how do these two different types of plaques appear? Homogeneous plaque has a uniform low-level echoes, but again, the most important component is that it's less than 50% sonolucent. This is an old image from the pathologic study I did comparing plaque to the en-bloc specimens. But here is a more useful, more recent example, and what we're seeing is homogeneous plaque. We're seeing it within the internal carotid artery, and we're seeing it in this transverse image as well. So again, this is the residual lumen, as we all know, and this represents the plaque here, and there's virtually no lucency within that plaque. So this would be type 4 plaque, but I simply call it homogeneous plaque. And I think that's all you need to differentiate homogeneous from heterogeneous. Another example of homogeneous plaque is seen here. And we can see on the sagittal image, the plaque is here and anteriorly as well. And in transverse, we're able to see the residual lumen. And again, we can see some sonolucency within the plaque itself, but it's less than 50% volume. Again, very important to look and quantify in your mind. You don't have to measure it, but you have to qualitatively assess, is it more or less 50%? In contrast is heterogeneous plaque, which I've said has more than 50% sonolucency. And again, a sagittal and transverse example here. The plaque surface can be smooth or irregular in heterogeneous plaque. Generally, in homogeneous plaque, the surface is smooth. For those of you who are worried about ulcerations, forget it. You don't need to worry about them characterization with ultrasound. All patients who have ulcerations fit into the heterogeneous category. All patients with ulcerations have heterogeneous, so you don't need to subdivide. You just want to understand the big issue, heterogeneous, homogeneous. Again, so let's look at some better, more recent examples. This is a color image showing the internal and external carotid artery, which helps us determine that this is the residual lumen, so this represents all the plaque volume. And you really need to characterize the plaque on the grayscale only. You can't characterize plaque in color or power imaging. So here we're seeing the residual lumen, and we see it's virtually completely sonolucent. This is type 1 on the international system, but for simple purposes, heterogeneous plaque. Heterogeneous plaque. Another example, the arrows are showing that for me. They're outlining the edges of the plaque itself. The volume is 50% more sonolucent. And it's nearly completely sonolucent, so I'm categorizing it as type 1, but it could be type 1 or type 2. Doesn't make a difference. This is heterogeneous plaque. And this is the kind of plaque which is vulnerable. This is the type of plaque which can break and embolize. Heterogeneous plaque is the vulnerable type of plaque. Homogeneous plaque is the stable type of plaque. How do we know this? Well, there have been outcome studies which have been performed. Nicolaitis classified plaque into the four different types that I've told you about and followed them for a little more than a year. All these patients had more than 50% flow-limiting stenosis. But the issue is the differentiator between them was the heterogeneous or homogeneous plaque. And he found that if it was homogeneous plaque, or type 4 of the international system, but homogeneous plaque, the incidence of CT infarction, as evident on CT, is 10.5%. If it was type 1 or heterogeneous plaque, the incidence of CT infarction is evident with 65%, 66%. Significant difference, an independent risk factor. Now, what is exactly happening in plaque? So it's very complex how it forms, and my ideas really come from reading the literature about coronary vessels. So we have a milieu of abnormal flow patterns in the vessel itself. Some of these are related to environmental factors, such as smoking. Some of these are related to the geometry of the vessels, which I think is probably related to the genetics. You know, how does the internal and external bifurcate, at what kind of angle? They cause abnormal flow patterns, which causes endothelial damage. In response to endothelial damage, you have intimal thickening. As a result of the intimal thickening, you get beginning to get ischemia of the vessel wall. As a result of the ischemia, then, you get the vasovasorum developing as an attempt to revascularize the wall. Now, these vasovasorum come from the adventitia, extend through the media into the intimal surface. Now, the interesting thing about the vasovasorum is the fact that there's a discontinuous endothelium which doesn't have supporting smooth muscles, so smooth muscle cells. And as a result, it's unstable and can break and rupture. And this is exactly what causes intraplaque hemorrhage. The vasovasorum extending into the intimal surface with the continuation of the milieu of these environmental factors, the continuation of these abnormal flow patterns, and without the smooth muscle wall, the vessels break and you get intraplaque hemorrhage. So we actually have the situation in which now, with ultrasound, we can differentiate a stable form of plaque, which is homogeneous plaque, from the unstable form of plaque, which is heterogeneous plaque. Again, heterogeneous is vulnerable, unstable. Homogeneous is the stable form of plaque. With ultrasound, we can differentiate these with a sensitivity and specificity in my work close in the 90 percentile. Recently, the people in MR have been able to reproduce this kind of work, and they're reporting it in the literature and being published as if it was not possible with any other modality. It is. You just need to spend the time and effort to do it. Now, how do you do it? How can we effectively characterize plaque? Why aren't you doing it? Number one, mistakes that people make. You can't look at the image with color. You have to look in grayscale because the assignments of when color is on, the grayscale assignments change dramatically, and you can't successfully characterize anything. You have to turn the color off, the power off, and only image the vessel in grayscale to look at the vessel wall to make a certainty of what type of plaque it is. Remember also, heterogeneous plaque is unusual. Homogeneous plaque is 80 to 85% of the time. You shouldn't expect to see it all the time. And don't be discouraged if you don't see heterogeneous plaque a lot, because that's not the way it happens. Most of the time, it's homogeneous. That plaque, there will be some vasal vasorum in there. They will, ultimately, in time, some of these will rupture and become heterogeneous, and then as the extension of the intraplaque hemorrhage goes to the intimal surface, it can rupture in the intima, causing the distal emboli. So again, this is what you want to look for, who's at risk. Now, why haven't you been able to successfully do this? I think the reason is most people don't look at it carefully enough in the transverse image. If you look at these two sagittal images in a drawing that I made, one would look like it was homogeneous, obviously, and one would look like it's heterogeneous. But if you look at this transverse image, a drawing, and I'm trying to show that this is heterogeneous plaque, just accept my drawing limitations. The sonolucency should be greater than 50%. But if you draw a line, a sagittal line through C, it'll appear as if it's a false negative for heterogeneous plaque. If you draw a sagittal line through the appropriate area, you can get it appear homogeneous. And this is what our technologists do, or we ourselves, if we're imaging it. If we're not imaging in the transverse plane, we can't get a true opinion of that plaque. Let's look at this drawing, the same thing, the same bottom, the same pictures on the bottom, but you could see plaque, as we know, is irregular as it forms. Whether it's homogeneous or heterogeneous, it's irregular. And if you can imagine, if we draw C prime, we'll have a true positive, but if we draw a line through D, it'll appear as if it were heterogeneous plaque. So you must, I repeat, must evaluate the patient transversely as well as sagittally, but more importantly, focus on the transverse images. And many people don't do that. Some new information that's being developed, unfortunately not in the United States, but internationally, with the use of contrast. They've been able to show that actually we can see the vasal vasorum with contrast and see it within the plaque. So this is substantiated. We can visualize this, and we can perhaps, and with time, when we're able to do this more commonly with contrast, we may be able to more effectively determine this. But in studies on the use of contrast, it's shown that the degree of prevalence of neovascularity, or the vasal vasorum that we're seeing, occurs more often in highly echolucent or heterogeneous plaque. So again, it ties in. This is integrated, it really ties in, it works effectively. And I would urge you, when you go back home, to try this. You don't have to rely on MR to characterize plaque. You can effectively do this in your own home. Now let's talk about the second component that we need to do, which is evaluating flow-limiting stenosis. Remember, these are two independent examinations really tied into a single charge. So remember also, give an appropriate amount of time to characterizing the plaque. I've seen technologists around the country who spend 30, 40 minutes trying to get the highest peak velocity in the internal carotid artery and spend two minutes looking at the plaque. These are two independent examinations. I urge you to spend some effective time trying to characterize plaque, as well as the effective amount of time trying to maximize your Doppler spectrum analysis. So how do we do Doppler? Most of you are familiar for the carotid arteries. We're using velocities as a surrogate to identify flow-limiting stenosis, because as we know, as the vessels narrow, the velocities increase in order to keep a steady state of flow to the brain. So as it increases, the velocity, as the degree of narrowing increases, the velocities increase until a critical period of time, and we'll talk about that a little while later. So we get images, we identify the vessels, and you again need to know a little about the anatomy to identify the vessels, but remember the external has branches, the internal doesn't have branches, the internal is bigger, it's usually medial, and and larger than the external carotid artery. And you could do other things such as temporal taps and so forth. But once you've identified the vessels, we take peak systolic velocity of the internal and the end diastolic velocity and do the same thing for the common carotid artery, approximately 1 to 2 centimeters proximal to the bifurcation in a non-obstructed portion of the common carotid artery. And we get these numbers. So here the internal carotid artery is 444, it's the peak velocity. The end diastolic velocity is 157. And similarly, we have numbers for the common carotid artery. And we put those numbers, we can put them into tables. Here is, again, the numbers we had for the internal, here for the common, and then we get ratios, a peak systolic velocity ratio, and also an end diastolic velocity ratio, and we put it into a table and figure out the degree of stenosis. So you could use this table, which is from the SRU. There's another table, which I'm the first author of, which was previously published. You could use any of the tables. And it would be nice if everyone agreed on numbers, but the reality is, and that's probably why most of you are here, because there's a lot of different numbers out there in the literature, and everyone wants to know what are the right numbers. Okay, what are the right numbers? And I'm asked that constantly. I don't care about the rest of what you said. Just tell me what to use. It's not so simple. Okay, it's not so simple. Why? So I think if you understand where the numbers come from, then you'll be able to make an independent judgment yourself and understand what you really want to use. So there are two different methodologies that have been established to measure narrowing of the internal carotid arteries. The one that is most popular now in the United States is the NASIT criteria, which means that you measure the residual lumen of the internal carotid artery and you compare that to a non-obstructed portion of the common carotid artery, and you have a little formula, 1 minus A over C times 100, and you get the degree of stenosis. And this is based on an angiogram, and our ultrasounds can be correlated to those numbers as well. The other methodology, which was actually older, was the European carotid stenosis methodology, and that's comparing the residual lumen of the vessel to the outer margins of the vessel. Now, this can only be seen with ultrasound because you can't see the outer lumen of the vessel with an CTA or an angiogram. And so that's why the NASIT criteria was started, because we wanted to compare it with an outcome to an angiographic correlation. But these are two valid methodologies which were used. The table that I was the senior author of initially used the European method. The table for the SRU, which I'm an author of as well, tried to use the NASIT criteria. Now, why is this so important? Okay, look at this diagram that I've drawn. Say the carotid bulb measures 3 centimeters, and you have 1 centimeter of plaque on either side with a 1 centimeter residual lumen. And then the internal carotid artery also has a 1 centimeter diameter. Now, if you measure it by the European carotid stenosis trial methodology, it would be a 66% stenosis. If you measure it by the NASIT criteria, the 1 over 1, it's no stenosis. Now, why is this important? Because if I've convinced you at all about the value of plaque, it's very hard to explain to a patient that you have vulnerable plaque at risk for embolic stroke, and you probably should have an endarterectomy, and certainly not an angioplasty and stent if you have heterogeneous plaque, if you have zero stenosis. I mean, it's very hard for them to understand that but if you use the NASIT criteria, you might be saying they have zero stenosis. Now you're saying, well, that doesn't occur. Well, it actually does occur very often. This is an example. This is probably around a 10% stenosis if you measured it according to the NASIT criteria, and a much higher stenosis if you measured it along the European stenosis methodology. So even though CMS is telling us we must put in all our reports that we're using the NASIT criteria, I don't think, in the United States at least, not in Canada or not in Europe, but in the United States, the final word is not in. Okay? Because I think the issue of identification of vulnerable plaque, unstable plaque, is an independent, significantly important risk factor. And I think we're going to have to go back and really deal with that more effectively than just saying that it is plaque exists and the degree of stenosis is something else. We need to characterize that plaque. We need to identify the issue of who's at risk of vulnerable plaque. So again, going back, just to remind you that there are two different tables, and these are present in the literature. This is one I published as the first author in radiographics way back in, I think, 1989 or 1990. But if you just Google my name, you'll find the table. And the second, and the differentiator on this table is that for 60 to 79% stenosis, it's a little less than 170 centimeters per second peak systolic velocity, rather, it's greater than 170 centimeters per second. The end diastolic velocity is 40. The systolic ratio is 2 and 2.6. For an 80 to 99% stenosis, it's 250, 100, 3.7, and 5.5. Now, the more recent table, again, I'm an author of this. I don't have a vested interest in either one of these tables. I just want you to understand that there's differences and you could work effectively with either one. This is the table from the SRU Consensus Conference, and the numbers are relatively similar to the other table since I was there and helped participate in it. But 50 to 69% stenosis is in this range, again, greater than 2 systolic ratio, and diastolic velocity of 40, and they don't use a diastolic velocity ratio. And then for greater than 70, again, similar numbers, except a little higher in the end diastolic velocity in order to characterize these things. But again, you just need to, you can Google these, and you will find them. Again, if you Google my name, you'll come up with both tables, and you won't have a problem. You don't have to copy down any of these numbers. So what you really want to know is which velocity is correct. Okay, I come back to that area. Don't bother me with all this information. Which one is correct? The problem is that they're all correct. Okay, the reason is it depends where you want to be on sensitivity and specificity curves. You need to know a little about statistics, and actually all I know is very little about statistics, but let me try to explain to you some of the things I do know. So if you increase the systolic velocity as a cutoff number to identify 60% stenosis, the sensitivity goes down and your specificity goes up. Okay? Now this is the same thing for no matter what table you're comparing with. So it depends where you want to be on the sensitivity and specificity curve. So in the past, we would do ultrasound as the absolute first screening test, and patients would then have a follow-up test, whether it was an angiogram, in some cases CTA, and you may still be doing it in your institution. If you're doing that, you want a high sensitivity test and low specificity, right? Because it doesn't matter. You want to make sure that you don't miss the disease. In contrast, if you're sending the patients to the operating room or having an angioplasty and stent immediately following, you want to have a slightly lower sensitivity and a higher specificity. You don't want to put anyone at risk for something, a significant risk, if they don't have the disease. So again, it's where you want to be on the sensitivity and specificity curve. Neither table is right, neither table is wrong. A cutoff number is wherever you choose it. If you have something that's working effectively in your department, you can continue to use it, as long as you communicate actively and avidly with your vascular surgeons and cardiologists who are doing the interventional work. So let's talk about what are some of the pitfalls in your interpretation. And I have a long list, which was a whole hour, so I'm going to shorten it to the key components. Very important would be you cannot rely on one criteria. So there are some national screening things that exist which they only take a peak systolic velocity and they use that as a screening test. Some of you may have been doing some of that at home. You don't want to do that. You have to integrate the information. Let me show you some examples of why you don't want to do that. Here, if we have this internal carotid artery, the peak systolic velocity is 166. The end diastolic velocity is 79. I'm even giving you two criteria. Okay, and according to the SRU consensus table, it would be a 50 to 69% stenosis. But if you're careful enough and you do the common carotid artery, you'll see that common carotid artery velocities are 96 and 36, and the systolic ratio is 1.7 and the diastolic ratio is 2.2. That is less than 50% stenosis. What's happening in this patient, he has hypertension. So all the velocities are elevated. Very common. You'll see this all the time. You must use all the criteria. Probably a more concerning issue would be this one. The systolic velocity of this internal carotid artery is 67, okay, and the end diastolic velocity is 23. No matter what table you look at, you would say it would be less than 50% stenosis, less than 40% stenosis. But if you look at the common carotid artery velocities and you make the ratio numbers, you'll see it's 2.9 systolic velocity ratio and 2.9 for the end diastolic velocity ratio. This is a 50 to 69% stenosis in a patient who has a cardiomyopathy. So you would have completely missed the significant flow-limiting stenosis in this individual. So again, you must use all parameters. And another common mistake people use is they don't understand how to deal with the patient who has a atrial fibrillation and a compensatory pause. They have the highest velocity, so the technologists who are trained always make sure you find the highest velocity. Frequently will write that on your information and send it to you. If you're not looking back at the images, you may mistake this yourself. You don't want to use compensatory pause. You have to use normal sinus rhythm. And if you can't get an appropriate normal sinus rhythm, you can't use these criteria. You must have so in this, for example, case, I would have used this systolic, rather this spectral pattern here to get the appropriate measurements, not this one. Another problem, and again, very important, high-grade stenosis. Remember I was talking to you about this well-known diagram in which shows that as the velocity increases, as the degree of stenosis increases, the velocity increases in order to keep a steady flow going to the brain, as I described. But at some critical point, right, at some critical point, as the degree of stenosis goes to occlusion, you're going to get no flow, and the velocities have to start decreasing. So more than 90% stenosis must begin to approach normal velocities. If the velocity is 700 over 150, it's not a 90% stenosis. If the velocity is 100 over 60, it may be a 90% stenosis. You have to deal with the image that you're seeing as well as the velocity numbers and integrate the two together. Okay, you have to make sure when you're seeing normal numbers, there's not a flow-limiting stenosis on your images, as well as to try to figure out where the degree of stenosis is. You can correlate it. It's not really that difficult. You need to correlate the image that you're seeing, the color picture or the power image transversely of the residual lumen, and correlate that with the velocity numbers that you have. Right? So if you have a very small residual lumen, you would more or less expect to see elevated numbers, but if you see a small residual lumen and high numbers, you probably have a very critical stenosis. All right, what about angle position? Everyone is worried about angle theta. This is an example to show you what we're talking about. Here is 60 degrees, here is 70 degrees, the same patient, just a slight movement, and you can see the significant difference in velocities. Remember, you have to have it 60 degrees or less when you're integrating that vessel wall. I think everyone knows the short answer, but everyone needs to practically apply that. What about dampening? What about looking at symmetry of vessels? This is a good example of what dampening looks like. There is no diastolic flow. We call that dampening. And luckily, we always have symmetry, although people can have bilateral abnormalities, but in this particular patient, we don't have it. We see a normal common carotid artery, which is high resistance, but does have diastolic flow. In contrast to this one, has no diastolic flow. We know when that occurs, more commonly than not, you're going to have either a distal stenosis, or if you still have dampening in the internal carotid artery and you're looking distally, you may have an intracranial stenosis or an intracranial obstruction. So even if you're not visualizing the intracranial vessels, you can tell that there is pathology in that area. So we interrogate the internal carotid artery, and in this example, you'll see it's very elevated, so this is a significant stenosis. Of course, we do the ratios and so forth, and this is the angiogram which demonstrated it. And also demonstrated, as we saw, the ulceration, but again, we knew it was heterogeneous plaque, so we knew it was potentially unstable. That's why we were moving forward with a process. Another form of asymmetry is, look at this, two common carotid arteries. Remember the last one had no diastolic flow. This one has some diastolic flow, but the pattern is certainly asymmetric. If we look at the internal carotid artery in this one, in case you're not sure, you can see a pattern that you're familiar with when you look at the renal arteries, and it looks like, of course, Tardus parvus, and that tells us always that there is a proximal stenosis, and in this case, a proximal stenosis within the innominate vessels. So again, even though if you're not seeing the stenosis itself, you can identify that there is a problem in that area. So in summary, with regard to the duplex examination of the carotid vessels, the carotid evaluation involves plaque characterization and stenosis grading, both. 2 independent examinations. Again, you need to spend a considerable amount of time on both. You can't just spend a short period of time characterizing the plaque to put it in a report and then spend all the time trying to get the high degree of stenosis. The categories that I suggest that you use are heterogeneous, homogeneous. I'm sort of simple. It's yes or no. It's either heterogeneous or it's homogeneous. The way we distinguish it is by looking at the amount of sonolucency within the plaque volume. Remember, heterogeneous plaque histologically correlates with intraplaque hemorrhage, and that's vulnerable plaque. And when I see that, I call the clinicians. It's vulnerable. That patient's at risk for embolic stroke. And now, if the degree of stenosis is more than 60%, they will do endarterectomy rather than angioplasty and stent in these people. If it's less, they're going to start them on antiplatelet therapy at whether it's 20% or 30%, it doesn't matter. They're going to be started on antiplatelet therapy, which I'd recommend that you take home and recommend that they do as well. A homogeneous plaque is the stable form of plaque. And if it's the high degree of stenosis, it could be treated differently. Right? More logically, those will be done with angioplasty and stent because you don't have the risk of the plaque breaking down and distally embolizing. If you have a patient with the same degree of stenosis and it's heterogeneous plaque, I really would urge you tell the vascular surgeons to operate on this one, not the cardiologist to do an angioplasty and stent. And I think you will positively influence that patient. Remember, significant stenosis and plaque characterization are independent risk factors. The key factor, again, to identify heterogeneous plaque, again, is more than 50% sonolucency in the plaque volume. And again, remember, transverse imaging is important in the characterizing of the plaque. Duplex ultrasound is accurate to assess flow-limiting stenosis. The SRU consensus group has recommended the table. It's no longer particularly new. I guess I should change the slide, but it's been around for a while. But either in the article, either table is recommended. And again, as long as you know how to effectively use it, and as long as you understand where you are on the sensitivity and specificity curves. So you need to be talking to your carotid, your cardiologist. Now many of them are doing angioplasty and stent. You actually have outcome information. If you talk to them, you could correlate the angiograms that they're doing pre-stenting and look at that and make sure that where you are in the sensitivity specificity curves to make sure you're accurate. And remember to integrate all anatomic and physiologic data to make an accurate diagnosis. And by careful attention to detail, you can avoid the pitfalls and improve the accuracy of your assessment of the duplex carotid vessels.